Hello, good morning, everyone.
Good morning.
Hey, I am Janani at the College of Public Health, Assistant Professor in the Department of Health Policy and Management. I have to start from Melissa Jones, thank you. And if we have any technical problems, please direct the message to Melissa Jones using the Zoom chat feature. So I take this opportunity to welcome you all to the session on behavioral health. We are happy to have you join us at this year's State of Public Health Conference, along with our presenter. And I take this pleasure to introduce Mr. Jim Lankford, who is the Executive Director and President at the Georgia Prevention Project and the head of the Substance Abuse Research Alliance, who is the presenter for today's session. And I am equally excited as all of you to looking forward to this session and to learning a lot about this really important topic on behavioral health, especially now. So the platform is all yours, Mr. Lankford.
Very good, thank you. I appreciate your help very much. Well, we all know how bad the pandemic's been, and I'm talking about the COVID pandemic. And of course, we have been labeling for many years now, 3 or 4 years at least, about the opioid epidemic that we've had going on in the United States. And so that epidemic, or as you know, has not been in front and center in the headlines over the past many months, and that's unfortunate. So what we're going to try to do today is give you a little bit of an update. Where do we stand with regard to the opioid and heroin problem in Georgia and across the country? It's not a good story at all. And you can imagine that the COVID pandemic has really exacerbated dramatically the problems that we thought we'd been making great gains, and we had been in the opioid and heroin problem in Georgia and in the country. But that's not the case now. Many things have turned around in a very negative direction. So I'm going to talk about those things as well. I can't quite tell if my co-presenters are on or not. And maybe Johnny or somebody can help me out. I'm trying to scroll through the list and see.
They were stuck in the main session before I just got over here, so I think they're trying to get assigned now.
Okay, very good. Well, I'll stall for just a minute until they get here, but they're terrific people who have great expertise with regard to substance use disorder issues in Georgia. I've been working with some of them for a long time, and they are great. We are very fortunate in Georgia to have the professionals that we do that have been working on substance use disorder issues in Georgia for quite some time. I see Caitlin on now. I'm going to see if Aaron Johnson is on. I don't see him on yet. And
we were all having technical issues, but we are here.
Okay, all right. Well, I'm stalling just for a minute until there's Aaron. I see Aaron now, and I assume Neil Campbell will also be.
Yeah, she's trying.
Will be joining us as well in a moment. Anyway, I'm Jim Lankford. I can start with my intro at least of who I am, and then we'll move on to the others. I'm not going to do long bios on everybody. I'm going to do short ones, because we got a lot of other important things to talk about than our own. There's Neil. Great, Neil. Glad to see you. And so I'm going to do short bios for everybody who's on here. But my co-presenters here have very long bios because they're really cool people who've been doing this work for a long time. I have a strange background that goes back to political work and business work. I ran technology companies for 20 years. I helped create the Georgia Meth Project, the big anti-methamphetamine campaign for Georgia more than 10 years ago now. We morphed ourselves into opioid and heroin work about 6 or 7 years ago, and we now call ourselves the Georgia Prevention Project. We also then created the Substance Abuse Research Alliance, and I'm going to talk about that in a few minutes as well. Neil Campbell, I'm going to give Neil a little longer intro here in a moment when I let her speak. but she is the executive director of the Georgia Council on Substance Abuse, and again, with a long career in this work. Aaron Johnson is at Augusta University. His title's so long, I'm gonna have to wait and read it off my paper later, but he's, again, been doing this work for many, many years. Caitlin Merchant, who is Director of Programs at Georgia Prevention Project. And so Caitlin also with an impressive resume. So here's what we're gonna do. I'm gonna talk about where we are and give you some national figures and state figures about what's been going on with the opioid and heroin problem in this in the middle of this COVID pandemic. And I'm going to give you some of that work and update. And then Neil's going to dig in a little more on treatment and recovery issues. That's her expertise. That's what her organization is focused on. She's also done a lot of work in public policy and that kind of thing. I'm going to let her talk about that. Aaron's going to talk about some very specific projects that have been working on across many counties in Southeast Georgia, and other work that he's been doing. So really on the ground, hands-on work. Caitlin's going to talk about prevention work. Now there are a couple of different definitions of prevention in this world, and so I'm going to need to tell you about those, explain those a little bit. We're all focused on overdose prevention, yes, but and treatment and recovery is part of that. But there's also something called primary prevention, and that's Caitlin's going to focus a lot on that, which is how do you begin to educate younger people about the dangers of substances, about the problems with substance use disorder, to divert them away before they ever get started in these substances, protective factors, things that are going to protect these kids as they move forward. Because the further off you can put their first trying of substances, then the greater chance you have of them not becoming addicted later when they do start trying substances in their 20s. So Caitlin's going to talk about some of that work as well. I'm just trying to get some terminology straight for you. I'm going to go to my PowerPoint quickly here. And for Neil and Caitlin and Aaron, I'm going to run the PowerPoint for you so we don't have to switch control back and forth. You just need to tell me when you want me to change slides for you. So I'm going to go to my PowerPoint here and go share. And then I'm ready to go. If I go from the slideshow and play from the start. So again, we're here to talk about the substance use disorder, the impact of COVID-19 in this group. I've already introduced who we are as our presenters. The SARA group, and I didn't mention that too much, but that is the Substance Abuse Research Alliance. That's a group that we created out of the Georgia Prevention Project in 2016. It's about 200 agencies, individuals, nonprofits, for-profits, governmental agencies, academic institutions, state and federal agencies, even some elected officials show up at our meetings. We invite any of you that want to show up to do that, and send me a note later and give me your email address, and I'll be glad to put you on the list. We are due for a SARA meeting sometime later this month in January, and so I'll put you on the list for that meeting. We talk about policy, planning, research, all those kinds of things. Our key thing that we're known for, one of the key things that we're known for, is our white paper we created in 2017 with an update early in 2018 that laid out 10 recommendations for the state of Georgia and for the Georgia legislature. And we got most of those done, which is remarkable to some degree. Now, some of those were carried to a maximum degree, and that's the state strategic plan for combating opioids and heroin. That was a big one for us. And DPH took up that piece. We worked closely with them in part of that planning process in 2018, and it's continuing today. But it launched with a big bang in the last part of 2018 and continued with heavy work in 2019 and 2020. So that group, DPH's work there has been truly great. We looked at a lot of different states, and I can go on and on about that in terms of where Georgia was in 2015 and 16. And we were way behind a lot of other states in work that they had done at identifying this problem. And so I was very concerned about that. And so were other members of SARA. And we went to work, and we found a way, to really push forward. And I really think Georgia has one of the best strategic plans now for addressing the problem. This is one of the maps. I'm going to put this up here for a couple of reasons. One, to show you how badly how things have changed over the past year or so with regard to the opioid and heroin epidemic, but also how the pandemic has affected where we are. But I'm also putting this up here to show you that Georgia has some really good data at the Department of Public Health. They've come on very strongly the past 3 or 4 or 5 years, putting this data together, getting emergency room data, overdose data of all kinds, death rates and death data, all of that, and done it by county. And so they've done a really super job on that, and they do a great job of presenting it in their website. You got to kind of dig down to find it these days, because it's not. It used to be top of line, first thing you saw when you hit their website, and now the pandemic has kind of taken control of some of that. But what you're going to see here, and I'm going to show you this slide and then the next slide, and this shows you where we were before the pandemic started, and this doesn't show it. Things were going down. I mean, things were doing really well in Georgia. A gradual, steady, slow decline in opioid and other overdoses going on in the state. It shows you the hot spots, as you can see, Metro Atlanta area, and then some other counties. There's Augusta, that area, Columbus down here, Albany area, Valdosta, Savannah, and that kind of thing. Heavy concentration here in Metro Atlanta. And then this map over here shows you which counties were worse. We're having the worst problems in particular. What was the biggest increases in overdoses and emergency room visits, and those outlined in black were the 5 worst. And that's Bartow County and Carroll County. I think that's Dougherty County down there, Valdosta, Lowndes County, and then down here on the coast in Brunswick. And so those were the worst counties in terms of how things had changed from one year to the next, one reporting period, 1 year to similar kind of quarterly period of the next year. Well, here's what it looked like then, and take a look at this because it's going to change. Here's what it looks like now over this past year, and particularly up through November. And so it's comparing June to August of 2020 to September and November of 2020. So just that change alone, but you can also see the visits, the number of visits to emergency rooms, how these have been concentrated. A lot more red spots, a lot heavier red, a lot more problems in these counties. And again, I'll switch back for you, there and then to there. So you can see what's happened just in a very graphic kind of way. There's lots and lots of stats that can go into to back this up, but we don't have really time to go into all of those. I will show you, here's another look at how this, one of the pieces of information that Georgia Department of Public Health has, and this shows you the overdose visits in November 2020, and they were predominantly female, they were predominantly white, and heavy in the ages of 25 to 34. Average, years of age, 28.7% of these people were in this group here. And you can see these bars over here are showing the ages and how that compared from 2019 to 2020 in those changes. So you can see what's going on there. Other demographic issues over on that side as well. This shows you how things compared year to year. Well, things were doing pretty well, and I won't bore you with this too much because it's a little complicated to look at. I've got another slide that may show it a little better for you. But things were going down in 2019. In the first part of 2020, they started ticking back up in 2020. Here's what it looks like nationally. This was a 12-month period. This was over 2 one-year periods, comparing those again from 2019 and up to 2020. And then afterwards, again, this is the 12 months ending in May of 2020. So, and this one, the first one shows you all fatal drug overdoses over those, comparing those 2 year periods. Georgia's not quite as bad as some other states, but if you look at then fatal overdoses involving synthetic opioids, then Georgia's right there in the worst of all the other states. And so that's an important one for you to look at. Here's one from the CDC that shows progression of overdose deaths by quarter, 2019 to 2020. The important thing, and there's too much detail for you to really be able to see. This is a good CDC report. You can find it through the Georgia Department of Public Health website as well. The important thing are look at these bars here. You know, these are the bars that started in April, you know, of 2020. And so you begin to see these, you know, how these things have changed and how this uptick is fairly dramatic. But what you can also see is that this is a progression. I mean, this is not, this is a national, this is showing pre-COVID bars over here, but the uptick was going on there even during that period. And I'm reminded, and I'll leave you with this because I want the other panelists to be able to jump in. But I'll leave you with one thought. And this was a conference I went to 2 years ago in Florida. And it was a stimulants conference, you know, about the rise of stimulants and methamphetamine, cocaine, all these other things. And one guy gave a terrific, you know, 2-hour presentation, hour and a half, 2-hour presentation on the history of these different types of surges of different substances, everything from stimulants to cocaine to opioids. I mean, the morphine problems, you know, all the way back to 1890 and moving forward. And what he showed were these different surges and drops in different substances, with one taking the lead and the other dropping off. What he then showed was the scariest slide at the end, which showed that over the past 3 or 4 years here in the United States, all of those substances, all of them are coming forward all at the same time. Now, some of that is because you're getting overlapping use of fentanyl, you know, those sorts of additives in some of these substances for sure. But the point was that he made at the end is this is not an opioid epidemic. This is not a stimulant epidemic. This is the substance use disorder epidemic, that all of these things are coming back strongly. And so this is perhaps a graphic representation of that, but it's also showing what has happened with regard to the COVID-19 problem and how it has made these problems much worse. So I'm going to shift now and let Neil Campbell jump in here. I'll give you a little more information on her bio. She has got a long history, as I said before, of work in this area. In 2009, she co-founded the Certified Addiction Recovery Empowerment Specialist Academy. That's called CARES Academy. And they've trained over 720 people in recovery to deliver support services in this arena. She's done a lot of work in jails, juvenile justice, adult corrections. She has a history of that in law enforcement as well. She was head of the organization in Georgia we call DBHDD at one time. So she has a great long history, and some of that comes out of her personal recovery background as well. Neil, I'm going to run the PowerPoint for you. Bring yours up.
Awesome.
And there you go.
Great. Thank you, Jim, and thank you so much for asking me to be here today with Aaron and Caitlin. They're really smart. They're the smart ones. I just want you guys to know that starting off. I'm going to talk a little bit about recovery. As Jim said, I do have I've done a lot because I'm old mainly, but I'm also one of the things that I talk about first and foremost is that I'm a woman in long-term recovery. And for me, that means this past July marked my 30 years in recovery. And I also in July turned 60. So I have been in active recovery half of my life now. And it is the pleasure of my life to work in this organization, the Georgia Council on Substance Abuse. This pandemic has been a huge struggle for people like me, people in the recovery community. I'm going to talk a little bit about that. But Jim, if we can go ahead and move on. So the mission of the council is to increase the impact of recovery in our communities through education, advocacy, training, and peer recovery support services. And who we are, you can go ahead, Jim. So for 20 years now, we celebrate our 20-year anniversary at the council. I've been here a little over 12 of those years. We've been a voice of recovery and a voice of, as Jim said, treatment and recovery in Georgia. And we provide advocacy, training, education, and peer services. We want to ensure that the recovery voice is at every table. We've gone from 12 years ago, there was just me. We have 35 employees now. We all have lived recovery experience. One of the things we're really proud of is that we have helped to get operational local nonprofit peer-run organizations all across the state, and we're the network coordinator for that. And you can think of us as the Home Depot of recovery. You can do it, and we can help. Go ahead, Jim. And so we're the staff is a diverse community of individuals. We believe that there are many pathways to recovery. One of our goals is to increase and to develop the peer workforce. So it's people like me who are in recovery who are doing a bunch of different things. I'm going to talk about that. So the way we see it, there's 3 challenges that individuals and communities face. And we do believe in a public health approach to people with substance use disorders because we're facing isolation, we're facing stigma, and we're facing extremely limited resources. And so we believe in support the restoration of wellness of individuals, families, and communities. And a public health approach for us is to do a lot of stigma reduction and a lot of education. I just stuck this in here because last legislative session, we got a license plate. We're going to be starting to sell that this next year. There's going to be a Recovery is Real license plate, a Georgia Recovers license plate. So when you talk about stigma reduction, one of the things we want to see is everybody who supports recovery and is an ally for recovery to get this license plate. Go ahead, Jim. Stuck that in there. Sorry. So I want to talk a minute about peer recovery support services. Jim showed that how the increase in overdoses over this last year has gone way up. We currently are operating in 3 rural hospitals in Northeast Georgia. We have peer recovery support services there. I'm going to talk about that. We also have peers in our NICU departments, our neonatal intensive. 2 of the 3 of those hospitals that we're in neonatal intensive care units as well. We also have a warm line. It's a peer support warm line. I'll give you the number of that later. We're open from 8:30 in the morning until 11 at night. You can talk to somebody in recovery, whether you're an ally trying to get somebody services or if you're lonely. We have seen a huge increase in that, as you'll see. And then we also operate all recovery meetings because we had to get virtual really quickly. One of the things we always say is that human connection is the opposite of addiction. And when everybody shut down, that was devastating for our community. And you can see that the rise that data shows is not even close to what's actually happened. There are so many people who have had a setback in their recovery because of the loneliness and the fear, some of the racial injustice we're seeing that's happening in our communities. That's a factor as well. So you can go ahead, Jim, to the next one. Just want to talk a minute about the Northeast Georgia Community Connections. This is where we have our peers. So if someone has a diagnosis or has a substance use issue in these 3 emergency rooms in Northeast Georgia Health System, they are offered a recovery coach. And virtually everybody accepts that. And our coach just meets them where they are. We connect them with services and supports in the community. We do a lot of training with the hospital staff. The hospital nurses and docs and the EDs are telling us that we help change the culture because they see people in recovery talking to others and see how that is. We use appropriate language, person-first language. We don't say someone is an addict. We say someone is a person who is struggling with substance use disorder or somebody who's seeking recovery. And we connect these folks. So we've had this is old, we've had over 5,000, close to 5,500 encounters in these hospitals. And that's for all drugs. That's not just overdose, that's not just opiates. You can imagine, those of you who work in the public health space know that alcohol is the greatest driver of people to emergency rooms. That has held true. But we also do a lot of follow-up calls. We've been in these emergency rooms for 3 years now, and we have 2 follow-ups every day, and we have some people that we've been talking with for 3 years and helping out in the community. Go ahead, Jim. We also are in the neonatal intensive care unit, where we have that. This data is old. I apologize. It's a long story. We have seen given support to over 300 families, and we've done close to 2,000 successful follow-ups. And what we help moms mainly and families who have been diagnosed or have been using alcohol and drugs during their pregnancy. They get a recovery coach. And what we've done is we've we've gone from 19 days that a baby spends with neonatal abstinence syndrome spends in the emergency or in the NICU. From 19 days, we're actually down to 8 days. So if you can think of the cost of that, we have, it's the return on investment of having a recovery coach, the 4 coaches that we have up there are women who were in active addiction during their pregnancies and are in long-term recovery now. They have over 2 years of recovery. Most of them have closer to 5. Actually, one of them has over 10. And so they have successfully navigated the DFAC system, the court system, and they've got their babies back, and they're helping other families do the same thing. Okay, Jim. I know I don't want to take up too much time. So we do the warm line. This is the CARES warm line. Find the number on there. It's 844-326-5400. It's right in the middle. We were averaging before COVID about 1,000 calls a month. And post-COVID, we are now up to 1,700 calls a month, our coaches. It's not only have these calls increased in volume, they've also increased in length, and they've increased in intensity. Our coaches are helping people, a lot of them in rural communities, and I think Dr. Johnson's going to talk about the Rural Communities Project, but you get lonely when you're in recovery and you don't have anybody there to point out what's working well and to say that it's going to be okay. It really gets scary. And so the intensity of our calls have just gone way, way up. And we also talk with a lot of families who don't know what to do. They don't know what, they don't know what addiction is. They don't know what, when should I be worried? Or I have a family member who is, how do I walk with that person? And we teach them that. We are very much, the model that we use on our phone and in the emergency departments is intentional peer support, where we walk alongside people as they choose their own recovery path. Again, we support many pathways to recovery. Go ahead, Jim. Next one is our all recovery meetings. I know this is big. You can go to any of our social media. We're on Twitter, Instagram, YouTube. We're on all of the channels, all of the social media. You can go and find us there. But every day at 10 o'clock and at 7 p.m., 10 in the morning and 7 at night, we have virtual all recovery meetings. And we have anywhere from 10 people to 60 people joining these meetings. They are not 12-step meetings. They are literally all recovery. Everybody is welcome. So you don't have to be in recovery. You could just want to talk about issues that are related to recovery and sign on. We pivoted. We actually did this. I feel so grateful that we were Zoom literate before the pandemic hit, because right when it hit, we did a quick pivot to virtual meetings, and we're literally listening to and providing support for thousands of people a month. We saw a need for an LGBTQ meeting that people, and so we have now on Thursdays at noon, you can join an LGBTQ meeting. We have people from all over the country joining that. And then every Tuesday at noon and at 8:30, we have Spanish speaking meetings as well. None of these things were in place before COVID, but they have been in place since then. And we have our coaches are the ones that fill in and facilitate these meetings, and they've been really successful. So I just wanted to, this has been, as I said, a really tough time for our community. We'll do anything we can to reach out to them. I personally had never been to a virtual 12-step meeting. I'm a 12-stepper, and I never had been to one until the pandemic, and I joined. There's a group called intherooms.org, and you can have it. There's 12-step meetings all over the world, 24/7, and it really has been a lifesaver for many of us in recovery to stay connected. One of the things that we have learned is that there are a lot of people won't get up and go into a 12-step room physically, but they will sign online. So that's been a real gift as well. Zoom is one of the, you can actually have the protections that you need on Zoom as well. You can have moderators, because in the beginning we were getting Zoom bombed a lot, but these meetings have just been a lifesaver for everyone. And you can go to the last one, Jim. I just want to say in closing that we believe that substance use disorders are a preventable, treatable, chronic health condition, and that people get better, but that we have to listen more to people in recovery, that we should have people like me, people like my staff, people all over Georgia, the tens of thousands of people in Georgia who are in recovery. We should be asking them, what helps you in your recovery? How do you stay well? What are some of the things that you do that help you in this epidemic? And we should start highlighting those, because until we start listening to people who are impacting, we're not going to have the impact that we really need to have. And Jim, I'll turn it back over to you. There's a way to contact me, I think, the next slide, but I can put my contact information in the chat box. Oh, I think you're muted, Jim. Oh, maybe not. Maybe it's me. Oh, are you there?
Sorry, I was on a private mute. I didn't mean to cut off your last slide there. I'm sorry.
No, that's okay. That's what you go, recovery_GCSA, and that's my email. And please reach out if there's anything I can do or anything me or my staff can do for you.
Good. Thank you so much, Neil. Thank you. Let me jump into the next one here. Next is going to be Aaron Johnson. Aaron, as I mentioned to you, is at Augusta Augusta University, sorry. Let me do slideshow from the start. Shoot. Aaron is a professor, and he's also director of the Institute of Public and Preventive Health at Augusta University. He's focused for many years on the adoption and implementation of evidence-based practices, focusing primarily on SUD treatment. His current work includes a SAMHSA grant for SBIRT. We'll explain more about what that is, screening, brief intervention, and referral to treatment. He has a grant from the National Library of Medicine that utilizes tablet technology to deliver health literacy information to incarcerated individuals. And then a SAMHSA grant, or a HRSA grant in 22 rural counties in East Georgia, and he's going to talk about that as well. He's been widely published in journals across many disciplines of public health, nursing, medicine, addiction, psychology, and sociology. Aaron, take it away.
Thanks, Jim, and thanks for inviting me, and thanks. It's great to be on the panel with Neil and Caitlin as well. Neil and I have known each other for about 20 years, which is hard to believe, but it's been great working with her over the past couple of decades. So if you can pull up my slides, we'll get started. So what I wanted to cover today, we have 3 active projects that are in the field. 2 of them are SAMHSA funded grants. One's a HRSA funded grant. All of them are focused on prevention and treatment of substance use disorders. And what I wanted to focus on is just the impact that COVID-19 has had on the ability for us to do our work. So, you know, and Neil did a good job of this too, and having to pivot immediately to virtual all recovery meetings in order to continue to do the good work that they're doing. We've had to do some similar changes with our projects in order to keep them up and running. There we go. So as I mentioned, we have 3 projects in the field. The first is an SBIRT grant, screening, brief intervention, and referral to treatment, focused in Georgia's rural and underserved populations. The second is another SAMHSA grant called the Augusta Area Comprehensive Offender Reentry Program that's focused on identifying and addressing substance use disorders in incarcerated populations and transitioning them into treatment services once they are released from incarceration. And then the third is an opioid response program that's funded by HRSA that focuses on a 22 county area, roughly in the triangle between Augusta, Macon, and Savannah.
Aaron, I'm a little lost. Are you seeing your slides correctly or not?
I see the second slide, yes.
Okay.
So you should just be able to do slideshow.
Yeah, somehow it got A little screwball. Okay.
Yeah, there we go. So that's the title
Okay, very
slide. Okay, I've already covered the second slide, so go
All
to the third.
Very good.
So I just want to give you a quick overview of each of those three. So the first one is the screening, brief intervention, and referral to treatment grant, and the project goals for that are to implement services in federally qualified health centers, so that everyone coming into that health center receives a brief screen, a single question screen for alcohol and for drugs. And then for those who are positive on those single question screens, to receive a full screen using some validated instruments, and then to deliver appropriate services, whether that be brief intervention, brief treatment, or referral to treatment. Another goal is to establish an efficient and patient-centered model of referral to treatment to increase the number of patients that are successfully referred from the primary care setting to a more formal treatment program, or to a self 12-step type group. And then by the end of the grant period, our goal is to create a sustainable model that can be replicated to other FQHCs throughout the state. The next slide. So this is the service area covered by that grant. So again, you can see that most of that for the most part, our counties of focus fall within the triangle between Augusta, Macon, and Savannah. There are 6 FQHCs that serve those counties, and so we've implemented SBIRT into all 6 of those FQHCs. Next slide. So there's a list of our partners: so, Christ Community in Augusta, J.C. Lewis in Savannah, Coastal in Brunswick, Oconee Valley Healthcare in Greensboro, East Georgia in Swainsboro, and Community Healthcare Systems, which is in Tennille or Sandersville. So the impact of COVID-19. So when things shut down in March, our FQHCs moved primarily to telephone or telehealth visits, and the services they were providing were mostly prescription refills and just chronic care services, which impacted our ability to deliver SBIRT services. So whereas before, when patients would come in, they would receive a single item screening question, and then for those positive, they would move on to a full screen by a behavioral health specialist. That really went out the window when the FQHCs moved to telephone and telehealth visits. They have since, beginning in mid to late summer, since returned to in-person visits while continuing to do some telehealth visits, but the result has been fewer patients coming into the FQHCs, and then additional work required by the FQHCs to see those patients. And so that has really significantly impacted our ability to deliver screening and brief intervention services, and impacted the number of people that we're able to serve. We've also seen a fair amount of staff turnover within the FQHC. So a number of the participating clinics have lost nurses, and the biggest impact for us is when they lose a behavioral health specialist and have to rehire a specialist. And in rural settings, it can take several months for them to locate and hire a new behavioral health specialist. And so the result of that is that we have had to go back to each of the participating sites and do retraining as they've brought new people on board, and really work to sort of make tweaks to the workflow in order to continue delivering the services that we are trying to deliver in those sites. So next slide. So the offender reentry program has been similarly impacted. So the program goal was to expand the availability of substance use disorders treatment and related reentry services to male and female offenders who have substance use disorders but are transitioning back into Georgia's communities. To be eligible, the participants had to have served at least 3 months in a correctional facility or 1 month in jail, and they have to be within 4 months of release. So we'll start services with them as they're nearing release. Next slide. So our project partners are the Georgia Department of Corrections, and specifically the Augusta Transitional Center. So the Augusta Transitional Center is located here in Augusta. It's a 220 bed all male facility, and everyone coming into the transitional center is nearing release. So most of them are within 6 to 9 months of being released back into the community. So that's really an ideal population for us to identify and start to deliver services as they prepare to re-enter their communities. And then we've also been working with Richmond and Columbia County jails to identify women who are in jail but about to be released back into the community. And our treatment provider is Hope House, which is an all-female facility here, but they actually have agreed to work with the men who are in the transitional center, and then also the Department of Community Supervision, the Augusta Office of DCS. So the impact of COVID-19, so since March of 2020, only residents and staff have been allowed into the Augusta Transitional Center. So we had originally embedded a behavioral health specialist into the transitional center to work with the men and deliver services while they were still incarcerated, and then to transition them to outpatient services once they were released. But we were no longer able to do that after March. In addition to that, the Georgia Department of Corrections stopped making transfers among facilities. So what happened was, whereas the transitional center had been 220 men, those men were starting to be released, and there were not new men coming in. And so at one point in late summer, they were down somewhere around 150 men. So we were not able to deliver services, and we had fewer men to deliver services to. So what we've had to do is to transition to virtual counseling and case management services. So we developed a brochure and a website with information about the program that we have provided to the transitional center, so that when they identify men that have a history of substance use disorders, they can provide those men with that information. And then everything that has to do with the services for the men while they are in the transitional center now has to happen virtually. So we have Hope House do a virtual intake with them, and then offer virtual counseling and case management services to them. So we provided tablets to the transitional center, so the men are able to see and work with the counselors that are at Hope House via the tablets. And then the final project I wanted to talk about is our HRSA grant. It's an opioid response program with 3 sets of core activities: prevention, treatment, and recovery. It's really a comprehensive approach to addressing the opioid epidemic within a specified area. And I think the next slide shows the area. Okay, maybe not. Maybe it's the one after that. So the three partners, these 3 partners are also working with us on the SBIRT grant. All 3 of these FQHCs serve the 22 rural counties that are the focus of this grant. And then in addition to those 3 FQHCs, we have the Georgia Council on Substance Abuse, which Neil heads, and they are working with us on the recovery component of this project, specifically doing listening sessions with individuals in those counties and trying to establish recovery community organizations in those counties. And they've been a fantastic partner. So you'll see the 22 county area there, the color coding, or the areas served by the different FQHCs. Next slide. Yeah, go forward. There we go. So these are really the core tasks. So increase access to naloxone availability for first responders. And then in addition to that, because the Medical College of Georgia is here at Augusta University, we also provide training to the second-year medical students and provide them with naloxone kits, because they are about to go out on their clinical rotations throughout the state. So this seemed like a great opportunity to increase access to naloxone, not only in those 22 counties, but throughout the state. Reduce stigma through community education, and then expand SBIRT in those federally qualified health centers. And then the treatment core task, increase the number of providers waived to prescribe medications for opioid use disorder, provide workforce development, and develop, recruit, and retain the behavioral health specialists, which, as I mentioned, turnover is an issue for them within those FQHCs. Offer an on-site treatment option through those behavioral health specialists, and then train the FQHCs on how to code and bill for those services so that becomes a sustainable service once the grant funding is gone. And then the recovery aspect, I already mentioned the role that Georgia Council on Substance Abuse plays for this core task. So provide training for peers interested in becoming certified peer specialists, develop local recovery leaders, conduct some workshops on building a culture of recovery in those different counties. And so the impact of COVID-19 for this one, so all in-person training and presentations have been halted in those 22 counties, which has made it very difficult for us to do the work that we had planned to do. I already talked about the impact that COVID had on our ability to deliver expert services. The medical student training for naloxone was delayed. It was supposed to happen in June. It did actually happen in December, so we're glad to get those medical students trained. We had to shift everything to virtual, so we've done several virtual listening sessions focused on different areas within our target counties. We've offered, and I say in quotes, a live virtual 4-hour training for providers that are interested in getting waivered to prescribe buprenorphine. So any provider in those 22 counties or even in other parts of Georgia that want to get waivered to prescribe buprenorphine, we've been able to provide virtual training for that. And then we've started to explore the ability to offer telehealth expert or telehealth buprenorphine because of our access issues in those 22 counties. But to date, unfortunately, we have not done any community-based trainings of any kind. So the effort to address stigma through community-based trainings has really ground to a halt. And that's it. That's the impact that COVID has had on us, and we've done the best we can, but it's been really difficult.
Aaron, thank you. Good job. I'm going to move on to Caitlin very quickly. If I can bring up her slides, I will do so. Let's see. All right. Try this one more time. Here we go. Here we go. And just briefly to introduce Caitlin to you, again, Caitlin is the Director of Programs at Georgia Prevention Project. She has oversight over 3 or 4 major programs there: Georgia Meth Project, Teen Advisory Council, and College Prevention Partnership Programs. When I hired Caitlin, oh gosh, 3 or 4 years ago, 5 now, I can't remember. It's been a while. 6. Oh my gosh. You know, one of the key things that I saw on her resume, I mean, she had a master's in social work from Georgia State, but what I was really interested in was that she had been a Peace Corps volunteer in Mozambique. And, you know, anybody who's worked with Peace Corps people in the past, you know, they can handle anything. You know, nothing rattles them. They've seen it all in the past. And she's done a terrific job for Georgia Prevention Project. Caitlin, thank you. And by the way, she just had a baby in the last 6 or 8 weeks. And so congratulations again. You're looking great as a new mom.
Thank you. Thank you, Jim. It's great to be here. I really appreciate being here with Neil and Aaron, especially just learning about all of the great work that's been going on, even with COVID. I know that that's been a challenge for pretty much everybody in the public health world. It's the same for prevention. As Jim mentioned, I'm really going to be focusing on primary prevention. So reducing first-time use among young people, but I will touch a little bit at the end on overdose prevention. Next slide. So first, I really want to dive into some of the issues, especially for young people. It's not much different than what older adults are facing. So we have the ongoing opioid epidemic. It hasn't gone anywhere just because of COVID. As we've seen, really, there are a lot of increased risk factors due to COVID. So our young people, they are moving to virtual learning. They're losing a lot of those social supports that they're used to. They're dealing with a lot of added stress, you know, seeing their parents maybe go through unemployment. There's suicide factors that are also on the rise. So there's a lot of isolation and despair, uncertainty. So just like we're all going through that, so are our young people. So it's been very important in the prevention field to focus on how can we increase protective factors for young people. So how can we, even in a virtual world, kind of build supports, bring our young people together, teach them positive, healthy coping skills to navigate this world that's so very different for all of us. Youth vaping is also on the rise. I know it's hard to see this chart over here, but you can see that close to 40% of high school seniors are reporting past year vape use. And that includes substances like marijuana that they're intentionally vaping. But a lot of times our young people maybe aren't aware that vape products contain nicotine. So that's kind of an issue that we need to be addressing. So for us, we're really looking at a polysubstance use issue. As Jim mentioned in the beginning, it's not one substance that our young people are facing, it's really a wide variety. So for us, we need to be talking about root cause issues and not focusing so much on specific substances. Next slide, Jim. So I'm going to talk a little bit about the Georgia Student Health Survey. This is what we in the prevention field use to kind of guide our work. It's a great tool because all middle school and high school students take this self-assessment report. It is anonymous, so the hope is that the reporting is accurate. It does include specific questions related to drug and alcohol use, so this is really helpful for our work to kind of pinpoint what substances are of concern. Next slide. So a great addition that happened from 2018 to 2019 was the addition of separate questions. So prior to 2019, students were asked if they were using painkiller or tranquilizers in the same question. So obviously this is a little bit problematic for us because when you're getting that data, it's showing everybody lumped in together or all those substances together. So we were able in the prevention field to work with the Department of Education to get that to be two separate questions so we can really narrow in and see which students are using painkillers versus tranquilizers. And you can see in the sample question that I included that now slang terms are used. This is very helpful because a lot of times a young person might not be aware of what is a tranquilizer, but if you say Xanax, that's something that they're familiar with. Next slide. So here we have, this is a chart by Dr. Jennifer Zorland out of Georgia State University. It's just showing the use for misusing prescriptions or taking it without a doctor's prescription. You can see the largest category here is for medical purposes, which kind of fits with what we think or what we know. Many young people are misusing prescriptions when they get it from family or friends. So the second largest category on here is that they're using it to relax or quiet their nerves, which again fits with what we know that young people are facing a lot of added stress, so they're self-medicating. Next slide. Here, I just wanted to really highlight the very early age of onset. So close to 30% of students responded first time use of a prescription drug without a prescription as being age 8 and under. To me, that's really shocking, but it just shows that there is need for early prevention. Next slide. So that's kind of where all the issues are right now in Georgia. Now I want to kind of move towards the more hopeful messaging because there is a lot of great prevention work going on around the state with us at GPP, but so many other organizations. So specific to GPP, we have our Teen Advisory Council or TAC program. And similar to what Neil and Aaron were mentioning, is we've had to move all of our peer-to-peer education meetings online to Zoom. So thankfully, we've been able to do that seamlessly. And interestingly, we've actually had an uptick in our participation, which I think it kind of speaks to what Neil was saying, where students feel more comfortable being a part of something where, you know, in person, they might not want to show up to a meeting. They might be a little bit uncertain, but if they have nothing better to do with their time, if they're at home, then why not go hang out with some of their friends through a Zoom meeting? So it's been really great. TAC is focused on prevention planning using the SPIF, Strategic Prevention Framework. So they're really trying to spread awareness, still host virtual events around prevention, even during this unique time. Next slide. The Quarantine Club podcast. I just wanted to highlight this. It's something unique that one of our TAC students created. It is available on Spotify. So if you have any young people that you work with, please direct them to this resource. It's basically a student telling her own perspective of how she's coping with COVID-19, sharing positive coping skills, really putting as much of a positive spin on it as she can while still being realistic. There is an episode for parents, so even if you don't have any youth that you work with, feel free to check that out. Next slide. We also have an upcoming vape prevention series through funding from DPH. So our TAC students are actually going to be facilitating this vape series for other youth. So there's a QR code on there. If you have any young people that you work with, please feel free to sign up for that. It's going to be 2 sessions in February and 2 in March. So it's a great opportunity for young people to learn about vaping in an environment that, again, is coming from their peers. There's going to be music, games, giveaways. So we try and make it as fun as we can since it is all virtual. Next slide. We have our college prevention partnership through funding from DBHDD. And 2 things I want to highlight. So we actually have 15 different CPP groups. And 2 things that I want to highlight are drive-through drop-offs. So as part of DEA's National Take Back Day, our colleges are moving the take-backs at drop-box locations to be COVID compliant or socially distanced, so that you're able to just show up, pull up in your car, drop it off, and you don't have to feel like you're putting yourself at risk. So if anyone wants more information on the drive-through drop-offs, feel free to reach out to me. Another thing I wanted to highlight was our Tick-Tock campaigns. If you don't use TikTok, it's at GA Prevention. Feel free to check out our page. I know that we're short on time, so I'm trying to go as fast as I can. But at GA Prevention, TikTok is a really great tool for prevention to reach young people. So I encourage everyone to step out of their comfort zone and check that out. And lastly, I want to highlight that It Takes a Village campaign through DBHDD. These are 5 priorities that everybody can take part in. So safe storage, monitoring your medications, keeping them away from other people who aren't supposed to have access to them, alternative pain management strategies, naloxone. Again, we want everyone to have access to that. GCAL is a great resource. Good Samaritan Law is very useful for everyone. So to learn more about that. So I think I did everything in the amount of time.
Good, super.
Yes. Thank you, Caitlin, Jim, Neil, and Aaron. I know we'll be quickly put back to the main room. So maybe we continue the Q&A through emails. If we could share all of the speakers' email. I'm sorry we didn't have time for Q&A. I will definitely for sure follow up through email. Thank you so much.
Thanks to everybody who participated. Thanks, Neil. Thanks, Aaron. Thanks, Caitlin. Great job.